Good morning, everyone. I'm Padraig Dixon. I'm a health economist in the primary care department across the road, and I also have an affiliation with you weren't supposed to see the Green Reaper just yet, with the CPM. And this talk is about a particular area of interface between the worlds of economics and the worlds of personalised medicine that's playing out, and that we think deserves perhaps more attention than it's received heretofore, and that's the intersection between genomics and insurance. It's useful just to think a little bit about what insurance is. So we're all playing chess with the Grim Reaper. And that's, our death is something that's certain, but the timing of that is unpredictable for most of us. Some things are certain at a population level, but we don't know which particular individual will succumb and when and how. And the idea of insurance is simply that we pool risks within a population, within a risk pool, and the majority of individuals who are fortunate enough to be well and don't make claims or demands of the insurance system support the minority who do need help. And there's a fairly long history of people thinking about insurance in relation to genetics. As some of you will recognize R.A. Fisher, who was talking in the 30s about the value for insurance of predicting ill health by using genetic data. But it took until the end of the 20th century before this became really a practical concern with the increasing use of diagnostic tests, particularly in relation to rare diseases. And in the late 90s, the insurance industry, through the ABI, the Association of British Insurers, developed a voluntary code in conjunction with the UK government. And this has had various names over the years, a moratorium, a concordate. But the latest version is from October 2018, and this is a voluntary code, so it doesn't have the force of law. It's not written into statute, but it's essentially agreement that defines principles and practices that the insurance industry ought to use when accounting for genetic information. And it refers to two types of test. So a diagnostic genetic test is one that confirms or rules out a diagnosis for a disease, particular condition. And the other type of test is a predictive test. So this assesses future disease risk in individuals who are asymptomatic, who might be at risk of a genetic disorder. And the code has two core principles. The first is insurers are not allowed to pressure or oblige applicants for insurance policies to take out either type of tests. The test could be disclosed voluntarily, but the insurance company can't force you to do that. In relation to predictive tests, and this is slightly more subtle, the results of a predictive test can only be considered if they're explicitly named in the code, the financial sum exceeds a limit defined in the code, and it relates to particular types of insurance. And just one test meets this, or these two criteria, and that's Huntington's disease, which is a very serious rare disease, and only for life insurance cover of a value over £500,000. And in some recent work that Annika and I and other colleagues from the CPM and colleagues at the University of Manchester examined, we looked at three ways in which genomics is changing that's going to pose challenges to the code, and which we feel need to be accounted for in future iterations and developments of the code to support not only patients and individuals and people applying for insurance policies, but also the insurance industry itself. And those are a belief that we have and some evidence that the distinction between diagnostic and predictive tests is increasingly blurred. Similar issues in pharmacogenetic testing and also in the prediction of phenotypes like healthcare costs or mortality using genetic data that would be very helpful to insurance companies, but potentially detrimental to the interests of individuals. So on that first topic, historically, so not so long ago in the 90s, if you're doing a genetic test, you probably had a positive family history, you probably had a lot of other information that would support diagnosis, and then the clinching bit of evidence might have been a genetic test that confirms the diagnosis that was made. With the explosion in genetic testing, the volume of information that's produced, the increasing number of variants that could be found in a particular individual, it's very difficult to know or be confident that finding a specific variant in a person that is known or not known to be associated with disease will have any consequences for the individual. So this challenges whether anything we identify, absent solid information on the phenotype, whether that's expressed by the individual or family history or other diagnostic information, would actually be useful. And one particular way this is manifesting outside the clinic is in relation to polygenic risk scores. So polygenic risk is the influence of many different genetic variants across the genome that might influence the risk for a particular disease. And because polygenic risk is calculated from lots of different influences, the distribution of polygenic risk in a population is usually Gaussian. It's a normal distribution. So if you look at the top percentile of that distribution, generally, many of the people in the top 1% are at polygenic risk for, say, heart disease or a particular type of cancer will not be the ones who get the disease. It will be people of lower polygenic risk who get the disease just by the nature of how that risk works in the population and how limited are the contributions of polygenic risk to overall disease risk. So am I predicting your risk if I know you're at high polygenic risk? Am I diagnosing? Probably not. So this issue also emerges in a similar but different way in pharmacogenetics. So this is the study of how variation to drug response in relation to effectiveness and safety is determined by genetic factors. And if you know someone has a particular pharmacogenetic profile that might have higher costs, you might need to prescribe them different medication, you might be looking at the second or third line treatment. So the classic example is an enzyme called CYP2C19. And if you are interested in prescribing someone an antiplatelet medication, such as clopidogrel, that's a prodrug, so it's biologically inactive. It's activated by the CYP2C19 enzyme. Many people, especially of Asian ancestral background, can't produce this enzyme, so this drug is more or less useless. And therefore, these individuals are then at high risk of experiencing the stroke or heart attack or other cardiovascular events that the prescription is meant to avoid. So if it is established that I am a poor metabolizer of this enzyme, are you predicting the future, some future event which may never happen, that in the event I'm prescribed an antiplatelet, I won't respond to it, or are you diagnosing me as being a poor metabolizer? So another example of where this blurring is becoming very complicated. The third area is that it is now recognized, not necessarily widely recognized, but healthcare costs are heritable. And this heritability has been estimated from twin studies as being comparable to incident cancer. So your genes are related to how much you're going to, inverted commas, cost the healthcare system in the future, or how much you'll have to pay for your own healthcare. And of course, it also predicts mortality, which is very interesting to life insurance companies. So you can imagine a world in which at birth, an insurance company calculates your future polygenic risk for healthcare costs when you're middle-aged and says, oh, I'm not sure I really want to insure you, or I'm going to charge you a lot. Even if that polygenic risk score isn't very predictive, it might still have some incremental information about how attractive you would be to an insurance company to insure. So that creates the risk of discrimination, and we need some thinking about that to avoid unintended consequences of using genetic information in this way. On the other side of the market, if the insurance company can't access that information, it's possible you have adverse selection. So this is where individuals who know they're at high risk of higher healthcare costs prefer more generous insurance plans because they want to be protected. So is that a real risk? Well, possibly. So this is a story that appeared in the New York Times a few years ago. So this lady was 77. She lived in Michigan in the US. Her mother had Alzheimer's disease, and as well as the clinical and humanistic burden of the disease, her daughter also witnessed the financial consequences of the disease in the US system. So this lady sent off, I think, to 23andMe, a direct-to-consumer genetic testing company, a swab to see if she had the risk-increasing alleles in the ApoE-O locus. So people who have two bad, inverted commas again, bad versions of this gene are much, much higher risk compared to population norms of Alzheimer's disease. So she had a positive family history, and then the results came back, and she did have these risk-increasing alleles. So she immediately took out long-term care insurance so she could pay or have support for her own care. Now, it's not clear that she told the insurance company that she's doing this or that she had ApoE4, the risk-increasing alleles in ApoE4. If enough people do this and the insurance company's no way of finding out that they've done this, then conceivably the cost of insurance becomes very high because the riskiest people take out insurance and incur the highest cost. In turn, that will cause the insurance company to increase premiums for everyone because they can't discriminate between people on the basis of the risk, and you get what's called a death spiral. Everything becomes more expensive, the lower risks stay away from the market, and eventually the market collapses. So in the US in the year 2000, there were about 120 companies providing long-term care insurance. Now there's about 10 or 15, which is partly this mechanism. There is legislation in the US to prevent discrimination in health insurance on the basis of genetic information, but not necessarily for long-term care insurance. So this is a real challenge, I think, that we need to think about. So this code, the current version of the code, as I mentioned earlier, was introduced in October 2018. There was a review last December, and this summer the government opened a consultation for responses from anyone who was concerned or interested. And the government was consulting on two key topics. The first was whether the definitions used for genetic tests were up to date, and we said they probably weren't for the reasons we've just been talking about. And then they also wanted to think about an approach for identifying which predictive genetic tests may need to be disclosed. So you might remember the only ones that you have to disclose now are, or the only one is Huntington's disease if you're applying for life insurance worth more than £500,000. The ABI commissioned the Centre for Healthcare Research at Cambridge to do some research on this. They created a framework and they had these 4 questions. And this all looks fairly inoffensive. It's not necessarily outrageous. It looks quite reasonable. But the issue was, it was assuming that you could distinguish diagnostic from predictive tests. And we argued in our response to the consultation that's probably not realistic. It wasn't clear in the framework that was put forward for consultation whether tests that would score highly in some categories and low on others would actually merit disclosure. And would it then mean that any test you do that has a genetic component could be characterized as being predictive and therefore would merit disclosure? And that could have unintended consequences. So that would require the insurance company to always act without error and interpret genetic results correctly. And we suggested a much wider discussion was needed about how genetic data could be used and should be used, and what might that wider discussion look like. I think we need some normative principles, so what we ought to be doing. We need to have a conversation about those principles. So for example, you might say, should individuals bear all of their own genetic risk? Should some of the individuals, or should some types of genetic risk be borne by individuals but not others? Should we think about minimizing the overall cost of insurance to society, subject perhaps to cross-subsidy from people who are lucky to people who are less lucky? Should we focus on the people with the worst genetic profiles or the highest genetic risk and help them? We don't have the answers yet, but we think a much wider conversation is needed, and perhaps an evolution and change in how the code characterizes tests as diagnostic and predictive, and then that's sort of the end of the conversation. If you are interested in this, the CPM will be hosting an event in May next year at the Wellcome Collection in central London. It will be a free event. We'll have people from industry, genetic counselors, clinicians, health economists, God forbid, and others. And we'd be delighted if you're interested in this, because we do need people to contribute to the discussion to help industry and government move forward, so the interest of consumers, patients, and the industry is supported. We also have a paper where we outline some of these issues, which is also freely available, and let us know if you have any thoughts on that. Thank you very much.